Well, welcome everyone to the ECG case for the week of March 4th, 2012. Got a great case for you. And to set this up, I need to let you know that I was away for about a week and a half in Singapore very recently at the end of February, and it was for a conference and some other type of academic activities. And so I had a chance to meet a lot of really, really great people out there in Singapore. Very exotic location. If you've never been there before, check it out. And they have a great system of emergency medicine. They're going through a lot of the same challenges we are, and a lot of really, really great, hardworking, and very cutting-edge people. One of the people that I met out there contributed this case. He sent it to me by email, but I met him personally out there as well. His name is Dr. Zulkarnain Ahmad, and I hope I'm pronouncing his name somewhat close to normal, but he goes by the name Zul, and really nice guy. He sent me this case of a 58-year-old woman that he took care of. It's a woman who's Chinese, and she had presented to her general practitioner complaining of syncope. Well, when she went to the general practitioner, he got this 12-lead ECG, and he was concerned enough about her that he decided to go ahead and send her to the local emergency department where Zul met this patient and referred her to a cardiologist because he was obviously concerned about the ECG abnormalities that you notice up here. What he saw was a right bundle type of pattern in V1 and V2 with this very unusual ST segment type of elevation. And so he was concerned about the diagnosis that we're going to end up talking about. He called up cardiology, and it turned out the patient had a low-grade fever of about 38 degrees Celsius. Cardiology may have been a little bit more swayed by the fever, and they repeated the 12-lead ECG. By this point, the patient's ST segment elevation had resolved, and what they really noticed was just a bunch of ectopic beats, not a whole lot else going on. And they weren't all that concerned, so they ended up discharging the patient. And Zul was concerned enough that he ended up tracking the patient down, called her back, and I should also mention she went through a chest pain protocol, and this was a repeat ECG that was obtained a little bit later on. And so again, some of these ST segment elevations are present in V1 and in lead V2. He was concerned. He brought the patient back, and she's getting a proper workup now. And what he was concerned about is what we're going to talk about today, and that is the Brugada syndrome. And so just to give you some information about the Brugada syndrome for those people that are not familiar with it, or a little more information for those people that are familiar with it, this is definitely one of those deadly diseases that can produce syncope in patients that all emergency physicians should know. And I would say most cardiologists know about this as well. Many of them do, especially the electrophysiology cardiologists. But as this case demonstrates, not all cardiologists are necessarily on board with this syndrome. So you, as the emergency physician, have to know about it because you can't rely on other people to always know about it. So what is the Brugada syndrome? It is an electrical phenomenon that was first described by the Brugada brothers in the early 1990s. There are a couple of really smart cardiologists, and they were down in Southeast Asia studying a condition that was associated with sudden cardiac death in otherwise healthy young adolescent boys. Now, at autopsy, these individuals had structurally normal hearts, and they thought it was probably a hereditary condition. But again, at autopsy, normal hearts, no atherosclerosis, no hypertrophic cardiomyopathy, nothing. It's purely an electrical phenomenon. And so what they first described in the early 1990s has now become a very, very hot topic in the electrophysiology literature. And they've had a couple of international consensus conferences on this topic. They now believe that the Brugada syndrome is not just a zebra diagnosis like we thought back in the 1990s, but it's actually a more common cause of sudden death than we ever before previously recognized. How common is it, you may ask? Go ahead and ask. So how common is it? Well, they now believe, based on the international literature that they've put together at these consensus conferences, that the Brugada syndrome may be responsible for up to 20% of all sudden deaths that occur in patients without structural heart abnormalities, or if you take all comers, may be responsible for 4 to 5%. In other words, 1 out of every 20 to 25 cardiac arrests in the general population. That's an enormous, enormous number of patients for whom Brugada syndrome is the attributed cause of their sudden death. The incidence varies in different populations, and this Chinese woman is certainly in the demographic that we would worry about in that it is more commonly reported in Southeast Asia, although what's unusual is she's a bit older than expected, and also we originally thought it was more common in men, and it may be, but it's clearly identified in both men and women. It's most common in young males, but men and women, every ethnic group, every country. First onset of symptoms is a little bit older than we originally thought, but about 40 years old is the first onset of symptoms. No one's really sure right now in the year 2012. People aren't really sure why you can live 10, 20, 30, 40 years, 50 years, 58 years, and have no problems, and then boom, suddenly one day you start developing symptoms. But the average age of first onset of symptoms is around 40 years of age. The mortality is pretty high. Some reports early on indicated that the mortality may be as high as 10% per year once symptoms begin. And more recent reports have indicated that maybe it's a bit lower than 10%, but still, it's a relatively high mortality. And if you diagnose this patient and they get the only known treatment that works, an internal cardioverter defibrillator, mortality drops down to pretty much zero from this condition. On the other hand, there are no antiarrhythmics that are known to be effective. In fact, many antiarrhythmics that we typically think of actually increase the chance of mortality. So what else can we talk about? The syndrome is characterized by a few EKG abnormalities, primarily localized to leads V1, V2, maybe V3, and we'll talk about those in a moment. This is an electrical phenomenon that tends to precipitate episodes of polymorphic VTAC, sometimes monomorphic, but more often polymorphic VTAC. And if you're lucky, it will terminate on its own. The person wakes up from their collapse, and they come in saying that they had a syncopal episode. If they're not lucky, it degenerates from VTAC into VFib and then sudden death. So you see, syncope and sudden death may very well, in many cases, be the same disease along the spectrum. If you're lucky, it terminates and they wake up. Again, these patients have structurally normal hearts, and they think probably about half the patients have a family history of this, but only about half, so you can't rule this out just because somebody does not have a family history of someone else having problems like this. So let's talk about the EKG abnormalities. The money leads you're going to look for are leads V1, V2, maybe V3. You'll see a right bundle or an incomplete right bundle type of pattern, and I'm going to show you a whole bunch of examples in a moment. And with this right bundle pattern, you will have some unusual ST segment elevation. The most specific and sensitive type is a coved type of elevation, so you get this right bundle pattern with a coved type of ST segment elevation. The slightly less common and less specific is this is an awful drawing, but a saddle type of morphology or concave upwards. And interestingly, the findings can vary depending on many factors, including medications. A lot of people believe that this is a sodium channelopathy. And so if you have sodium channel blockers on board, for example, cocaine, antidepressants, especially tricyclics, anticholinergics, and other sodium channel blockers, it will increase the chances of developing the abnormality and increase the chance of having the syncopal episodes. And in fact, the electrophysiologists use a sodium channel blocker to test for this condition, and if they infuse the sodium channel blocker and it brings out the Brugada pattern or it induces VTAC, then that confirms the diagnosis, then they place the ICD. Other things that have been shown to bring out the Brugada EKG pattern include fever or hot ambient temperature. It's an interesting thing that's been reported, and as you may recall, this patient had a low-grade temperature of 38 degrees Celsius, and maybe that brought out the Brugada pattern in this particular patient. And from day to day, the pattern can actually come and go, and it can go from the cove type to the saddle type. If you're not lucky, you may get the patient on a day where the pattern is just not there. Then you're out of luck. But if you see the pattern, you've got to worry about it. And as you recall, when the patient presented to the cardiologist, the pattern was not there, and that may have misled them into thinking that she doesn't have Brugada syndrome. But again, later during her chest pain course, the Brugada pattern came back, as I showed you. And that's very typical for the Brugada pattern to come and go. So again, I'm going to show you a bunch of examples. If you ever suspect it, send them for an electrophysiology study. The EP folks are the ones who confirm the diagnosis in the EP lab. There's two types of morphologies. the saddle type and the cove type, and I'm going to put a star there because the cove type is more sensitive and more specific. And I don't think that there's any electrophysiologist that would ever argue with taking the patient for an EP study if they see that cove type. The saddle type is a bit more debatable. Some electrophysiologists are not as conservative with the saddle type. They might let it go unless the person's got symptoms. But the cove type, a lot of the electrophysiologists that I know of and I've read from will say that when they see this pattern, they don't even care if the patient has symptoms or not. They're going to study that patient because this is a deadly condition if you miss it. So let's go through some quick examples. Just pattern recognition is very important here. You need to hammer home the patterns for these in your brain. So here's a very classic example. This patient actually had a bad outcome, but this was an ECG that was obtained on her, and you notice that there's a right bundle or incomplete right bundle type of pattern in V1 and V2, and you see that somewhat unusual ST segment elevation in leads V1 and V2. To show you some more examples, here's another example. Right bundle, incomplete right bundle-ish type of pattern, V1, V2, with the ST segment elevation. Another example, this is a patient that presented to her doctor's office, and this was the ECG in the doctor's office. She presented with syncope, and there's that pattern in V2 and also in V1 with that ST segment elevation. It's a little bit more classic looking in lead V1 in this particular case. This was missed by the primary care physician, and the patient ended up being discharged and had a cardiac arrest and ended up surviving, but with a very, very poor neurologic outcome. And now, I'm not going to argue that this is standard of care for primary care physicians to know about this. I don't know if this is even part of their literature, but I think it's really becoming standard recommended knowledge for emergency physicians and certainly for cardiologists. Even in emergency medicine, I've started hearing that this is now showing up on board exams. So this is really something that we all in emergency medicine have to know about. And as this case demonstrated, or at least the case I started with, not all of your cardiologists will necessarily know about this. It depends on what field of cardiology they're in. The EP folks all know about this, but a lot of the other non-electrophysiology cardiologists may not know about this yet, especially some of the older ones who didn't see this in their training. So you may be in the position of having to educate some of them. Here's another example. Again, incomplete right bundle pattern with just a little bit of ST segment elevation leads V1 and V2. You see that ST segment elevation there in leads V1 and V2. Now, for comparison, this is a normal right bundle pattern, and you recall that normally in the presence of a right bundle, there actually should be some ST segment depression. So if you ever see a right bundle or incomplete right bundle, especially in a post-syncope patient, and there's ST elevation, that really needs to stand out in your mind as being very abnormal. So just a few more cases. This is a bit more subtle of an incomplete right bundle in V1 and there V2 also. You see that saddle morphology. Another example, this is a very classic looking pattern in V1, kind of unusual pattern in V2. And interestingly, the electrophysiologist took one look at this EKG and said, that's definitely Brugada. I'm going to take this patient to the lab. The non-electrophysiology cardiologist who gave the formal reading on this, as you see, called this an acute MI because of the ST elevation. So again, there's a difference in knowledge and recognition between the electrophysiologist and the non-electrophysiologist. So keep that in mind. Here's another similar example. And in this case, once again, you've got that incomplete right bundle pattern in V1 and V2 with the ST elevation. And the formal interpretation, once again, by the non-electrophysiology cardiologist was nothing more than just an incomplete right bundle pattern. Nothing about Brugada pattern or Brugada syndrome in that particular case. Here's another example with the classic pattern in V1. And a couple more examples here. This was sent to me by a paramedic, Chris Tuzo, who's a real, well, he'll probably appreciate this comment. I certainly do. He's kind of an EKG nerd as a paramedic, and so he sent me a lot of great cases, and we've worked together on some other projects. This is a 40-year-old man that he saw presenting with syncope, and he recognized a Brugada pattern in V1 and V2, and this was confirmed in the EP lab. And this is another one that he sent. Now, this patient's presenting with chest pain. The last patient presented with syncope, the Brugada. Here's a patient presenting with chest pain, and this kind of looks like the Brugada pattern, doesn't it? Incomplete right bundle with ST elevation. But in a person presenting with chest pain, the first thing that should come to your mind is STEMI, and that's what this patient had. So the history of present illness obviously is going to be important. If you see ST elevation in V1, V2 with that right bundle pattern, in a person with chest pain, you're going to worry about STEMI. But if it's a post-syncope patient who's now saying, who's sitting in front of you saying, Doc, I feel fine, my syncope's gone, I feel better, and you see that pattern, you've got to worry. You've got to worry about the Brugada pattern. All right? So hopefully that's helpful. When you see that Brugada pattern, get on the phone with the electrophysiologist and tell them what you're worried about. And hopefully they'll take it seriously. You send them the EKG, they'll get them into an EP lab and study them. Because if you miss it, perhaps as much as a 10% mortality per year, this is one of the deadly causes of syncope that all emergency physicians need to be able to pick up. So again, thank you very much, Zul, for sending that great case. Best wishes to that patient of yours as well. And for all the rest, I hope this was helpful, and I will talk to you next week.